afternoon, colleagues. Welcome everyone to this month's installment of our TB Think Tank webinar. And the title of this month's webinar is Umoya, omuhle, TB IPC in primary health centers, what works and how it can be implemented. And just for everyone in attendance to be reminded to drop in their comments or questions under the Q&A tab, which will be addressed at the end of the presentation. And I'm going to hand over to my colleague to introduce our speakers for today.
Thanks very much, Leslie. We have a whole host of people who are going to be presenting to us today. We're going to start off with Dr. Indira Govender. She's a clinical research fellow at the London School of Hygiene and Tropical Medicine, based at the Africa Health Research Institute, Somkhele campus at KwaZulu-Natal. Her interests include TB, rural health, primary health care, access to care, sexual and reproductive justice, and anti-racism. We have Dr. Nikki McCresh after that. Nikki is an assistant professor in infectious disease modeling at the London School of Hygiene and Tropical Medicine. She is interested in the mathematical modeling of TB and in understanding the role of heterogeneity in the transmission and control of TB. She conducted the mathematical modeling work for Umoya, omuhle. Dr. Fiametta Bozani is an assistant professor at LSHTM. She works on economic and impact evaluations with a practical focus on model-based analyses to support decision-making and resource allocation for infectious disease and other primary care interventions. And Fiametta conducted the economic modeling work on the project. Dr. Tom Yates is a clinical lecturer at the UCL Institute of Health Informatics. His research interests include TB, CMV, epidemiology, and causal inference. Tom led the ventilation aspects of Umoya, omuhle. Prof. Karina Kielman is Professor of Equity and Health at the Institute of Tropical Medicine in Antwerp. She has long-term research experience in India, Kenya, and Tanzania, and has worked on health systems research projects in South Africa, Zambia, and Malawi. Her research interests include TB and health systems responsiveness and accountability. She was co-principal investigator of the project. Dr. Idris Kalan is a postdoctoral research fellow at the Center for Evidence-Based Healthcare at Stellenbosch. His research interests include continuity of care in people with TB, infection prevention and control, and systematic and scoping reviews. Idris worked on the policy and behavioral aspects of the project. Prof. Haley McGregor is Professor of Medical Anthropology and Global Health at the Institute of Development Studies. Her research interests include infectious disease and pandemic preparedness, antimicrobial resistance, informality in health provision, and concepts of care and chronicity in responses to lifelong illness, principally HIV. Haley led the infrastructure and organization of care aspects of Umoya, omuhle. And finally, Prof. Alison Grant is Professor of International Health and Dean of the Faculty of Infectious and Tropical Diseases at the London School of Hygiene and Tropical Medicine. She has worked in South Africa since 1997, focusing on the development and evaluation of interventions to reduce HIV-related illness and death, particularly HIV-related TB. Alison was principal investigator on the project. Thank you all very much for joining us today, and we look forward to hearing more about the project.
Thanks. May I start?
Yes, sorry, Dr. Govender, please go ahead.
Sure. Thank you. Hi, everyone, and thank you for attending our presentation. We'll be sharing our findings from our multidisciplinary project on TB infection prevention and control in KwaZulu-Natal and the Western Cape provinces. My name is Indira Govender, and I'm based at Africa Health Research Institute in Somkhele, omuhle, which and some of you may have attended our earlier webinars. So today we're presenting updated cost-effectiveness data, new results on improving thermal comfort, and sharing some thoughts on how the results might be implemented. Okay, yeah. And I hope you can see the order of presentation, but this is how we will structure the talk. So diving right into the rationale of omuhle. So health facilities have long been neglected sites of Mycobacterium tuberculosis transmission, and healthcare workers are at high risk of occupational acquisition of TB. There is, however, little evidence to show the impact of implementing TB IPC on reduction in nosocomial transmission. Our aim was to examine the social, biological, and infrastructural dynamics of TB transmission in 2 South African provinces, with the aim of informing health systems interventions to improve IPC for TB. And it's important to note that the data were collected prior to the COVID-19 pandemic. So there were 7 work packages corresponding to 7 research questions. The first 4 work packages involved data collection to inform intervention development. These included work on the policy environment, the epidemiology of TB transmission in facilities, the documentation of key elements of TB IPC, including ventilation, space, clinic design, and infrastructure, as well as people's movements within the space, and finally, healthcare worker and managerial perspective. That's how work package, which uses dynamics modeling techniques to map the dynamics of processes and factors influencing IPC practice and to identify plausible interventions. Mathematical modeling allowed us to estimate the impact of these interventions on TB transmission within facilities, and economic evaluation was conducted to estimate costs and cost effectiveness of the interventions. I'm going to briefly highlight the findings of our research that aim to better understand what influences TB transmission within health facilities. To simplify, the risk of contact with a person with infectious TB depends on the number of people with TB and the number of contacts between people with infectious TB and those without. The risk of transmission, given contact with someone who has infectious TB, is influenced by airflow, time spent together, crowding, and mass. And so the next few slides will highlight our findings in each of these areas. So our clinic TB prevalence survey was a random selection of adults registering at 2 primary healthcare clinics in KwaZulu-Natal, and all the participants were asked to give a sputum specimen regardless of symptoms. And among the 2,055 participants that we enrolled, 131 reported having 1 or more TB symptom, and 20 of these participants had TB cultured in their sputum. And of the 20 with TB in the sputum, 4 of the isolates were multi-drug resistant and 1 was rifampicin monoresistant. And 14 of the 20 reported no TB symptoms. So our conclusion here was that IPC strategies which depend on identifying symptoms will likely miss a lot of people with active TB. We then compared our findings to the results of a community-based TB survey that was conducted in the demographic surveillance area of Africa Health Research Institute during the same period. And we found that the facility-based prevalence estimate was only slightly higher than the estimated prevalence of TB in the community in rural KZN. Our ventilation measurements use 2 methods, carbon dioxide release experiments and paired indoor and outdoor carbon dioxide measurements. And our results from these measurements were that there was marked variation in natural ventilation between spaces. The least ventilated spaces were consultation rooms where doors and windows were closed to allow the air conditioning units to work. And fully opening doors and windows led on average to a 2-fold increase in natural ventilation. We then used a modified standard waiting time survey, which is used in many clinics, and unique barcodes and handheld scanners to track people from one space to another in the clinic to measure time and congregation. And we found that the median time in clinics was 2.5 hours, with 40% of attendees spending more than 3 hours inside. Most time is spent in indoor spaces. However, indoor time is reduced when the path through the clinic included an outdoor waiting area. Our findings on organizational culture, behavior, and practice were based on an ethnographic approach, so observations, field notes, and informal conversations in 6 primary healthcare clinics, and formal interviews with clinic managers, nursing staff, and IPC managers. And so some of these have to be translated and taken up at the clinic level. Services may need to be reorganized for staff. The perceived value of IPC is relative to other personal and professional priorities. We need to better understand hi, I had a bit of a disruption there.
Indira's been breaking up a little bit, but I think it's okay. I think people can see what you were saying because it's mostly clear on the slide, so I think it's okay to continue.
Okay, thanks. Okay, then so we then did our systems dynamics modeling, which was a way for policymakers and practitioners to identify and prioritize interventions. And so there were 2 workshops in Durban, Cape, and we had a combination of policymakers and practitioners. So this was of TB prevention and control. And then based on our input, we came up with a causal loop diagram showing the drivers and dynamic interconnected feed driving transmission of MTB at facility level. So high waiting times and crowding of clinics as influenced by an organizational culture wherein staff are overwhelmed by competing program and policy demands, which over time have created a conforming, compliant clinic environment wherein IPC implementation is not a priority. At policy level, there's limited consultation and learning from implementation challenges associated with IPC and no sense of urgency surrounding this. In conclusion, workshops identified 3 intervention targets, but also some elements that need to be considered when designing and implementing intervention mechanisms. This is the list of the final interventions discussed. In yellow, interventions which target ventilation and spaces, and in green, interventions which aim to increase personal protection. The first few you see aim to improve windows and doors than currently, putting in place building retrofits or installing ultraviolet germicidal lights. While mechanisms are simple, they are supported by common elements, for example, increased supervision, training sessions during which health staff are asked to consider what other measures they may need to follow to ensure limited transmission despite increased ventilation. And the intervention in green also promotes surgical mask wearing for patients and N95 mask wearing for staff. And as you can see, also includes workshops to promote behavior change. Now we cover interventions which are more complex, for example, ways to maximize the use of chronic medication to avoid persons coming and to introduce queue management and also appointment systems. The latter interventions particularly should be co-developed by patients and staff to ensure uptake and successful implementation. I will now hand you over to Nikki, who will describe the mathematical modeling. Thank you.
Thanks. So Indira has explained how we came up with a set of proposed interventions. I will now explain how we estimated their potential effects. And there are 2 mathematical models using this component of work, which I'll go through in turn. So firstly, I'll address the question, what proportion of MTB transmission to patients in clinics could be prevented by the proposed infection control interventions? The backbone to the model used to address this question was the patient flow data. I simplified the datasets to 4 key times: arrival, files, vitals, and leaving, And for each stage and patient, the most probable waiting area was identified. Missing data were imputed using multiple imputation. The model used was an individual-based model that tracks the location of each patient in the clinic over time and the overall numbers of people in each waiting area. I used the empirical data on ventilation rates and a Wells-Riley approach to estimate the risk of transmission over time. The first intervention I'm showing you the results for is an intervention to ensure that doors and windows are kept open at all times, maximising ventilation rates. And the bar there shows that the estimated reduction in transmission risk in clinics resulting from the intervention, and you can see that it's estimated to reduce transmission by around 25 to 72%. The second intervention is simple clinic retrofits. This could include installing lattice brickwork or whirlybird fans. This had slightly less effect on transmission risk than opening windows and doors, with an estimated reduction in transmission of 16 to 64%. Next, installing UVGI in all waiting areas. This is simulated in the model through an additional air change term, and we estimate that it would reduce transmission risk by 64 to 85%. Moving on to masks. This is surgical masks to be worn by patients, and we modelled a scenario where 70% of patients wear masks 90% of the time. This reduced transmission risk by 42 to 50%. The next intervention was to increase coverage of CCMDD among ART patients and to ensure that patients don't have to queue to pick up their medication. We estimate that doing that would have a moderate effect only on the frequency of visits for ART-related reasons, reducing them by only 22 to 34%. For that reason, the estimated transmission risk in clinics is reduced by 12 to 32% only. Next, a queue management system. This is a slightly more complex intervention, with the majority of patients assumed to wait in large outdoor covered waiting areas, and only a few patients allowed to wait inside the clinic at a time. We estimated that that results in reduction in transmission risk of 76 to 88%. Finally, we looked at the effect of introducing a daytime appointment system in clinics in KZN. We estimated that the appointment system would reduce transmission risk by 45 to 75%. To conclude, we estimate that interventions we decided on could reduce transmission in clinics by around 22 to 83%. Queue management system with covered outdoor waiting areas had the most impact, but installing UVGI had almost as large an effect and may be more feasible in many clinics. Moving on now to the community transmission model, where we aim to answer the questions: what proportion of tuberculosis in adults results in transmission in clinics? And what are the effects of the intervention on community-wide TB incidence and mortality? This work relied on two main data sources from within the project. The first was a community social contact survey, which was used to estimate and model the proportion of people's indoor contact time that occurred in clinics. The second data source was the increased prevalence of TB in clinic attendees versus the general population, which was used to parameterise an increased clinic visiting rate in people with TB. Here's a very brief overview of the model used. It's an individual-based model with a fairly standard TB natural history. HIV is modelled as HIV negative, HIV positive not on ART, and HIV positive on ART, and there's a complex contact and transmission structure, which incorporates the different amounts of contact time that different groups have in clinics. And they implemented the same set of interventions that we've seen so far. Firstly, the results for the proportion of disease that resulted from transmission in clinics in 2019. Overall, we estimate that 4 to 14% of disease comes from transmission in clinics. The proportion is slightly higher in HIV positive people at up to 20% and lower in HIV negative people. This is now the reduction in all incident TB cases in adults in the community between 2021 and 2030 that could be prevented by the intervention in clinics. The best estimates range from 3 to 8%, and the full range is 0.7 to 15%. The relative impact of the interventions on community-wide disease mirrors their impact within the clinics, with the queue management and UVGI interventions having the largest impact. To conclude, we estimate that 4 to 14% of disease results from transmission in clinics, and infection control interventions in clinics could reduce community-wide disease incidence by 3 to 8%. I'll now hand over to Fiamma, who will talk about the cost effectiveness.
Great, thanks, Nikki. So, I will take you through the cost effectiveness results that we calculated based on the same intervention activities that have been described by my colleagues and the related enablers in order to sustain full impact. The activities and the enablers were identified in collaboration with policymakers and practitioners during the first of the system dynamics modeling workshops that Indira described. And then we went off and built a cost model of intervention activities enablers and the consequential costs of TB treatment and ART using costs and quantities of inputs gathered from the literature, from ongoing research, quotes from local suppliers. Then the unit costs were validated with the system dynamics modeling participants at a second workshop. And lastly, the unit costs of TB and ART care were attached to the outputs from the community TB transmission model that Nikki described to generate cost effectiveness ratios under different intervention scenarios. The types of costs included in the economic model are illustrated here on this slide with the example of installation of UV lights. The core activities for this intervention would consist of installing the UV lamps, which is a once-off capital investment, and then the electricity for running them and periodic maintenance and calibration, which are all recurrent costs. The site-level enabler identified during SDM for this particular intervention is a dedicated on-site staff training by the Office for Health Standards with refreshers every 3 years. And then consequential costs of the intervention would be the reduction in TB treatment costs and ART costs, if applicable, that are realized thanks to transmission reduction. So these were estimated using the mathematical model. The core activities costed for each intervention are listed in this table. The interventions were specifically designed to suit the structure and characteristics of the 2 clinics in KwaZulu-Natal that were studied in the transmission model. So the economic analysis results are specific to these 2 clinics. Note that maximizing the use of existing CCMDD facilities was assumed to require no changes to the current operations of CCMDD. So the cost model for this intervention were the enablers and the consequential savings on TB and ART care only. And in this table, we have a list of the enablers modeled for each intervention. So as you can see, several of the interventions would benefit from the same enablers, such as additional and more frequent training sessions, intensified supervision from the district health office. So for interventions that require changes in behavior, not only for facility staff, but also for clinic attendees, we considered off-site community workshops to co-design the intervention and ensure community buy-in. Thermal comfort for patients and staff was taken into account for interventions that are meant to improve ventilation. So for example, by providing electric heaters or fans, depending on the season, as well as covered outdoor waiting spaces. So note that the model only considered site level enablers, so service level interventions. Then in this graph, we have the annual costs of implementing each intervention at the 2 study clinics, including the core activities, which are in the darker shade, and the enabler costs in the pale blue. It highlights the contrast between interventions with a larger or a smaller behavior change component. And this is in terms of the relative weight of the enabler costs. So the larger the behavior change required, the larger the enabler costs. That's kind of the rule of thumb of our results. So see, for example, how retrofitting buildings does not require any site-level enablers, whereas introducing an appointment system, relatively little additional investment in core activities is needed. But the enablers that are required for successful implementation are the most expensive. For combination interventions, the costs of core activities equal the sum of the individual intervention costs, but then the enabler costs are lower than this because some of the enablers are shared across interventions. And this table shows the consequential costs of TB care and ART for each intervention added up over the 10 years model time horizon. The TB cases and person years on ART under each intervention scenario are shown in the gray columns. These refer to the catchment population of the 2 clinics in KZN, which have a combined adult population of approximately 32,000 and 28% HIV prevalence. And here, the total intervention enabler and consequential costs over the 10 years modeled are added up and divided by the effect measure, which is disability adjusted life years. Each intervention is compared to the base case, so the status quo, and the difference in cost per DALYs averted for each scenario is the incremental cost effectiveness ratio. The CCMDD and retrofits interventions are both cost saving compared to base case. They are dominant interventions because they cost less and cause fewer DALYs in the population than the status quo comparator. Then the next cheaper intervention is the queue management system, followed by UVGI. Improving windows and doors opening practices is the most expensive intervention per DALY averted. However, it must be stressed that all these interventions are highly cost effective. This table shows the cost effectiveness expansion path of illustrative combinations of the proposed intervention. So the expansion path compares the combinations to the individual intervention with the lowest incremental cost effectiveness ratio, which in our case is CCMDD, and then illustrates the order in which different investment options would be recommended to the national TB program. Overall, we would recommend that the DOH adopt combination 2, although both are extremely cost effective. Combination 1 costs approximately 5% more than the most cost-saving intervention, which is CCMDD, and averts 21% more DALYs than the most effective intervention, which is a queuing system. So results are similar for combination number 2, which is marginally cheaper and more effective than number 1 in all efficacy scenarios, which means regardless of the initial assumptions that we made around the maximum impact of adding UVGI to the queuing system. So to conclude, at the moment, South Africa's opportunity cost-based willingness to pay threshold is estimated at approximately $3,200 per DALY averted, and the most expensive intervention that we model only costs about $151 per DALY averted. So the recommendation to the South African DOH would be to consider implementing all of these interventions and enablers. One limitation of our analysis is that we did not model all relevant combinations of these interventions. And another limitation is that we did not consider above service level enablers, things such as redesigning training materials, obtaining building permissions, or improving transportation links to clinics. So these barriers to implementation were documented by our social science and SDM work, and they have to be considered alongside the evidence from the modeling analysis when making decisions on TB IPC. Thanks very much. I'm now going to hand over to my colleague, Tom.
Thank you, Fiamma. Next slide, please. So you've heard from Indira already the kind of main findings from the ventilation aspects of the project, and one of those findings was that the least well-ventilated spaces were clinic consultation rooms where doors and windows had been closed to allow to maintain thermal comfort, for example, to allow air conditioning units to function, and this has been observed by others. Next slide. So thinking about the existing building stock across the 12 clinics, consultation rooms typically had open windows opposite a door that was closed during consultations. Corridors were often double loaded, that is to say, with rooms along both sides, and where there were only rooms along one side of the corridor, these rooms were often kept closed, as I've mentioned. Waiting areas commonly consisted of a central space with multiple directly adjoining rooms, for example, consultation rooms or pharmacies or files rooms, and all of these building designs taken together place limits on the extent of cross ventilation that is possible in these spaces. We received some money from the Colt Foundation to undertake some modelling building science work where we aim to find pragmatic retrofits that could maximise ventilation whilst maintaining thermal comfort. This was done in 10 clinical spaces across 2 clinics, one per province, The modelling was undertaken by John Taylor and his colleagues using Energy Plus, which is an extensively validated modelling tool that allows you to model indoor temperature dynamically as well as multi-zonal airflow. And the ventilation estimates obtained from the model were then translated into TB transmission risk using the Wells-Riley approach. So here are some of the interventions that we modelled. So we modelled the base case scenario and then a set of interventions to improve ventilation. So these included increasing window size or increasing the openable area of the windows. We also modelled fitting wind-driven roof turbines or whirlybird fans. We also modelled a set of interventions to improve thermal comfort. So this included adding a layer of insulation in the roof, increasing the roof mass by placing soil on top of the building structure, and fitting roof shades during summer months. Here are some preliminary results. So we found that roof turbines were more effective than changes to windows. This is perhaps unsurprising, given that, as I've described, many of the spaces were designed in a way that limited cross-ventilation. Roof turbines resulted in meaningful reductions in TB transmission risk, but as expected, we found that ventilation alone could not adequately protect individuals with heavy exposure, such as healthcare workers who were in the same space month after month. Our findings with respect to roof turbines are supported by empirical data published now more than 10 years ago by Helen Cox and Rod Escombe. In this study, they measured the effect of whirlybird roof turbines on ventilation in a number of clinic spaces in Kailicha. Another finding was that increasing window area had adverse impacts on thermal comfort. So in the winter months, heat was lost through the larger windows, and in the summer, excess heat was generated by sun streaming in through the bigger windows. Overall, sort of the modelling no active heating or cooling additional ventilation had a net positive impact on thermal comfort, and this comprised improved comfort over the summer months at a cost of additional cold winter days over the winter period. We found that pragmatic retrofits to improve thermal comfort had limited impact. It's quite difficult to passively offset large volumes of hot or cold air streaming into a space. So it's likely that additional active heating or cooling may be needed on hot or cold days, or alternatively on such days one might wish to deploy alternatives to natural ventilation such as UVGI. I'll now hand over to my colleague Karina Kielman.
Thank you very much, Tom. So the interventions we've been discussing comprise obviously administrative, environmental, personal protective measures, and they're often classified and ranked separately according to their relative effectiveness, but in reality they're interconnected. And our social science work looked at really the context of implementation and implementing these measures either individually or in conjunction. As mentioned, they're infrastructural, they're procedural, but they're also behavioral. And these components are obviously not implemented on a blank slate, but within a living, working environment of a clinic. So how does one actually take this environment into account when you implement measures, but also when you try to evaluate their sustained uptake? Next slide, please. If we look at the WHO conceptualization of core components of IPC programs, and this is not just for TB IPC, but for IPC programs in general, it includes an understanding of infrastructure of relevance to IPC. Just click next. So when we think about the control levers, they're often the most visible elements of IPC. The standard practices around masks or gloves or guidelines that are in place, or windows open or closed. The other things we see, they're sort of tangible. But the conceptual framework, if you look at it closely, extends beyond these kind of visible material elements to talk about the broader infrastructure that's kind of underpinning IPC practices and their sustainability in a clinic. And as you can see in the diagram, this wider set of factors affecting IPC is acknowledged in the purple area as the enabling environment. But the conventional approach to assessing IPC generally tends to be one of using checklists that privilege the particular set of practices. For example, wearing of masks, wearing of gloves, windows open or closed, committees in place, etc. And this standard approach still has quite a limited understanding of really what the enabling environment is. It focuses mainly on material components and the social infrastructure, in other words, the norms, the values, the practices that underpin why IPC is taken up and how, is often taken for granted and it's less visible. Next slide, please. So when we refer to the hardware of IPC, we generally mean the tangible elements of the system. So the people, the structures, the materials, the guidelines, money, committees, and so on. And when you assess IPC in facilities, if you look at checklists that assess IPC, they're often the things that appear on the checklists. But IPC implementation is obviously very dependent on what we would call software of the system. And here we're talking about the social and the relational aspects of work within a clinic. So issues like norms and values, the relationships and the roles of different health workers, their agency in terms of making decisions, and of course the ways in which policy processes are translated at the clinic level and impact on things like resource allocation and leadership and management and the ability to really, for example, follow up on infrastructural changes. Just click next. So this what we found in a very early scoping review that we conducted at the outset of the project was reviewing the literature, is that most literature on TB IPC focused really on the hardware of IPC, and there was much less literature focusing on the software, but clearly there's a real interdependency between TB IPC measures and the broader health systems within which they're implemented. And our work overall, particularly ethnographic work, showed really that clinic managers and frontline staff are constantly negotiating and adapting IPC practices within the infrastructural, the resource, and the organizational constraints that they find themselves in, but also within their own personal understandings of risk and safety. And we're going to see how this enabling or disabling environment for IPC plays out in two specific examples. Idris will first speak about the work that was conducted on mask wearing and the context of mask wearing and risk perceptions. And then Hayley McGregor will discuss examples of ventilation and patient flow. So over to you, Idris.
Thank you so much, Karina. Good afternoon, everybody. So following from what Karina said, the interplay between the hard and software of IPC implementation, this presentation focuses on risk perceptions and PPE among policy actors and clinic staff. So the broad questions we ask to explore these perceptions were: how have policies on IPC for DRTB and TB evolved and been implemented in the context of primary healthcare in South Africa? How does organizational culture influence healthcare worker and patient perceptions of risk and responsibility? The methods we use at the policy level: we had in-depth interviews with 15 policy actors. At the clinic level, we interviewed, it's actually 48 healthcare workers because we did some focus group interviews as well, in 6 primary healthcare facilities in the Western Cape. And I think this was earlier noted that the data collection happened before COVID-19. So the key perceptions of TB risk among policy actors, of course, there were other things that were found, but we are focusing on perceptions of TB risk among policy actors. And these perceptions actually informed what we explored in the clinics. Healthcare workers understand that TB risk they face, but too often feel powerless to address them. The policy actors also described how they were both individual psychological phenomena, and also these were socially produced and reinforced. We can see how these are mirrored also when we went into the clinic. The other emerging perception was how TB risk was located in TB spaces, such as TB wards and not in the general waiting areas. So among clinic staff, you can see how some of these perceptions from policy actors actually mirrored what we found in the clinics. Healthcare workers expressed that they felt more at risk of contracting TB while they were at work. They were concerned about patients who might have active TB that could lead to their infection. TB was seen to be located in areas within their facilities where it was necessary to wear a mask. And mask wearing, we saw that it's not only an individual choice, but rather a collective responsibility. This is one of the interesting quotes that we have where one healthcare worker was saying it's a challenge to wear a mask because other healthcare workers may think that you are making them look bad, and so do patients. If it is a uniform measure, it would have been easier. So what we conclude just on risk perceptions, of course, as I said, there are other things that were found. There's this widespread misconception that TB risk is localized to where diagnosed TB patients are, whereas in reality, TB risk is from people with undiagnosed TB, example in clinic waiting areas. The other conclusion we came to was that consistent mask wearing might become more routine feature of IPC in health facilities if managers more actively promote engagement with TB IPC guidelines and develop a sense of collective involvement and ownership of TB IPC in facilities. I will now hand over to Haley, who will take us through the material and social infrastructures of TB IPC. Thank you.
So I'm going to illustrate this point about social and material infrastructures for an enabling environment by talking about ventilation and patient flow, the latter to reduce crowding and congregation. And I'm reflecting views that we heard from healthcare workers, clinic managers, and patients. And finally, I'll report back on discussions we had with provincial architects in the Western Cape, reflecting on design processes. So firstly, considering ventilation. Airflow requirements were perceived by staff to be at odds with climactic and infrastructural conditions. So nurses and clinic managers complained of open windows making the spaces too cold for patients or staff, or on the other hand, interfering with the air conditioning. Additional views pointed to the problem of dust from open windows and concerns about privacy in consultation rooms. In addition, clinic staff pointed out that buildings were not always fit for purpose and imposed constraints, and structural changes such as retrofits were felt often to be outside of the control of facility staff, who reported that these involve complicated bureaucratic and financial processes. Next slide. With respect to managing numbers and flows of patients in order to avoid congestion and congregation, a number of elements emerged, as Karina said, relating to clinic design, administrative logistics, the organisation of care, but also the implementation of policy directives. So examples from our fieldwork illustrated how these elements could either create difficulties with congestion or in turn improve the flow of patients across the clinic day. Difficulties due to a lack of an appointment system, later concentration of people queuing in the morning and spending hours in the clinic. There were examples of constraints to IPC because of buildings not fit for purpose, for example, the lack of a sputum booth. We also observed that even in facilities with well-designed central waiting areas with extraction systems for ventilation, congregation could still occur in corridors not meant for waiting because of bottlenecks at particular points of care or staff shortages in delivering services such as vital signs checks leading to queues. Patients would be too afraid to move away from the door because they might miss their name being called. Furthermore, an increase in patient numbers in a clinic due to in-migration into a catchment area or people seeking care in a facility with a good reputation were also cited as causes of crowding. Finally, the organisation of clinical care pathways is subject to change as new directives come in regarding policies such as related to the Ideal Clinic initiative. Again, the material realities of buildings could make policies such as integrated care difficult to achieve. Another example was given when ways of working, such as the collection of files from a central registry, but this idea was changed, and this led to unintended consequences with respect to crowding and waiting times. Next slide. Finally, we held discussions with architects in the Western Cape, and they indicated the various considerations that they had to weigh up when designing new clinics, including but not only related to IPC. Getting a design implemented then also involves further discussion with public works regarding what can be built. And the architects confirmed that effecting structural changes to buildings later on is challenging, and that designs that confer flexibility, such as with movable wall panels, were considerations for responding to changes in the organisation of care or shifts in services delivered in a way that could still ensure IPC. Infrastructural and design approaches to IPC require consideration also of the actual flow of patients and staff and the use of space. And engineers and architects express desire for more bottom-up processes to hear the needs of staff and engage with colleagues, assessing service delivery elements in a more sort of co-design approach. So the final slide, in summary, considering the constraints and enablers to implementation of different measures, we encountered policy changes primarily aimed at improving and streamlining care. And these could obviously offer synergistic benefits for IPC, but also have the effect of reducing congestion in patient congregation. So these were certainly positive possibilities, but on the other hand, there were still constraints to be addressed related to both material and social infrastructures to improve ventilation and flow. And I'm now going to hand over to Alison Grant to do the final conclusions.
Thanks so much, Hayley. So it's my task to try to wrap up and summarise a few key points coming from this work. It's a massive amount of work to present it in 45 minutes. So I'm just going to pick out a few key things if we can go to the next slide. So IPC solutions, which depend upon identifying symptomatic people, is going to miss many people with TB. Another really key point is that TB transmission risk is widely misunderstood. It's thought to be in areas where there are people with known and TB people who are on treatment, whereas the real risk is for those who are not diagnosed, who are much more likely to be in waiting areas. In the new work on thermal comfort, it looks as if roof turbines, which have been previously suggested by South African authors, roof turbines sound like that may be a good way to improve ventilation while maintaining thermal comfort. Here's the next slide, yeah. I think overall, our work suggests that IPC may be more usefully framed as a systems problem and not as a compliance problem. If we see this as an issue that the nurses are not doing what they should be doing with respect to IPC, I think we're not going to come to the solution. We need to see our clinics as a complex setting and take that into account and think about how the setting needs to allow the different changes to happen. The system interventions for TB IPC, which were identified and prioritised by our policymakers and practitioners, were predicted to be effective and highly cost effective. Generally, they don't rely on reported symptoms. Many of them are less dependent on healthcare worker adherence, and some would have other benefits for patients, such as reduced waiting times. And as we've said, we did this work, or the data collection was done pre-COVID. Our calculations of cost effectiveness are only based on TB. If you also took into account COVID and other diseases which are transmitted by aerosol, the cost effectiveness, I think, would be even greater. So it now, oh yes, also to say that we know that the TB think tank prevention task team is currently working on IPC implementation guidelines for the NTP and the Medical Bureau of Occupational Diseases, which should be available later this year. And we hope that insights from this project may be able to help make the implementation successful. And if there's somebody from the prevention task team here, they may well want to comment on that. So I just want to finish by thanking everybody who made this very large project happen. There are very many of them, and we've listed many people there, particularly thanking our project oversight group who kept us making sure that we were going in the right direction. They're listed at the very bottom there. Thank you also to all of our funders. And so on the final slide, I think, oh yes, if you want any more information, if you just Google Umoya omuhle, you will get to our webpage. There's lots of our papers there, which you can find if you're interested, or if you want to contact any of us, we're very happy to talk to this or to discuss. And so now it's over to you for any, thank you for listening, and we welcome your comments and questions. So thank you very much, everybody.
Thank you so much to our speakers. Thank you for the very informative presentation. We have just under 10 minutes for any more questions or comments. Please be reminded yet again, drop your questions under the Q&A tab. I think for the benefit of the larger group, Alison, can you please respond again to the question that was added in the Q&A?
Oh, the CCMDD.
I'll just read it. Yes, I'll just read it and then you can just respond for the benefit of the larger group. So there was a question listed that asked what were the proposed CCMDD interventions, which illnesses and so forth. So Alison?
Yeah, so there, this was in our clinics in KZN, the great majority of people attending for chronic care are coming for ART care. And so the model was looking to minimize the number of visits made by people who were stable on ART. And so it was specifically about reducing the number of visits by people on ART to minimize that, so to minimize the number of people coming to clinic, to minimize congregation in clinics. But it was restricted. We didn't also look, for example, at hypertension and diabetes, but that's a much smaller number of visits. Hope that answers the question, Tom.
Thank you, Alison, for that. I just would like to also tell people that if you'd like to see yourself on this platform in the upcoming months, you can send an email to myself, which is nkosi@tbthinktank.org. It will appear on your screen shortly. So if you'd like to see yourself on this platform, do email myself to join in. So any other comments, questions?
This is Jody from the think tank. I'm going to hop in here while we wait for others to write their questions in the chat. Thanks so much for all of this work. This looks fantastic. I have a couple of questions. One is in response to GUV. One of the things that's come up is the issue of the impact on sight. So if you use GUV in some of these spaces where people are congregating, how can you protect people who might be overexposed to UV lights? And then the second question, if you don't mind me having a quick follow-up, is to ask about queue management, because appointment systems can be quite tricky, as I'm sure many people know, with not being able to predict necessarily when you'll be able to arrive on public transport. But are there any good recommendations for queue management that maybe we can take forward when we're presenting some of these findings to the Department of Health?
Sure, well, thank you for both of those questions. So with the GUV, Tom, would you like to talk to that one?
Yeah, that's fine. Thanks for the question. So I think it's, I think there is a risk to sight if installation is poor. So kind of if the radiation is coming down into the lower room, then that is potentially an issue. There's a large US randomized control trial in homeless shelters showing that with adequate installation, UV is safe. So Ed Nardell is the first author on that paper. And I think implementation, I understand lots of people are sort of thinking quite hard about models of implementation here. So I understand South African guidelines are being drawn up, and I think it will be important to think about how delivery happens, models of delivery and kind of processes to ensure adequate installation. But I think assuming we get the kind of model right in terms of installations and regulation and sort of monitoring, so you can measure the amount of radiation getting down into the lower room, then theoretically this can be delivered safely, but it's going to be a case of making sure that the models are correct. And I understand people at University of Pretoria, sort of in collaboration with people like Ed Nardell at Harvard, are kind of working on this actively currently.
Thanks, Tom. And for the second one about queue management, Sanj, could you answer that one?
I can have a go. Sorry, my camera.
You might need to speak up a little.
Sure. Sorry. Sorry. Yes, I wasn't presenting. I'm Sanj Karat. I'm a researcher in the project as well. Yes, I think there are a few potential options for queue management, but it gets quite tricky, and you sort of have to build them into filing systems. A lot of the same issues that came up with appointment systems also apply to queue management systems, and it will differ slightly for different queues. So in the workshop that we held, I think we had a few suggestions, and I can link to the report from our workshop on patient flow, but I can also have another look. It's been I don't have a more substantive answer at this time. So.
I think we could get back, if anybody is interested in that, I think we could get back to you.
Thank you so much for the answers and the questions. So I'd just like to announce our upcoming webinar in the next month, which is the Ascent team. It was already shown on your screens. So this will be our upcoming webinar in October. It will be showing shortly on your screens. So do join us again next month at 12 for that. And they'll be looking at the digital adherence technologies to support patients on TB treatment, South African results. So I think, Joe, do we have time for one more question? If you'd like to read that one for us, if you're able to.
So we have one here. To what extent do these results reflect the fact that this work has been undertaken in heavily researched sites? The proportion of undiagnosed TB may be smaller than in South African clinics overall.
Yeah, that's a great question. Although the clinics that we studied most intensely are in the Africa Health Research Institute's demographic surveillance area, I don't think that there's so much work going on TB case finding that would make a lot of difference to that, to be quite honest. So yes, there's quite a lot of research going on there, but I don't think the sort of research that's been happening recently would reduce the amount, would have had much effect to reduce the amount of TB that we found. But to some extent, to what extent can you generalize? It's always difficult to say, isn't it? On the whole, you would expect the prevalence of TB in KZN to be quite high because it has a high burden of TB, very much driven by HIV, coming down nicely now as ART is rolled out, but still quite high. So I think we can only study what we study. It would be lovely to do this in more provinces, but unfortunately we resource constraints. I don't know. Does anybody else on the team want to add to that? I mean, I think if the prevalence of TB was higher, I think you would expect these interventions to be even more cost effective, because you'd have the opportunity to prevent even more TB.
I know we're coming to the end of our session here, but I also wanted to ask about these turbines and the costing around those. Is there any work on the costing of those? Because that sounds also like a promising intervention for a resource constrained system.
Yeah, Tom.
So my understanding is that in the South African context, it's about $350 per turbine, and a turbine will buy you approximately 2,000 meters cubed per hour of air change. So so that's probably going to be a good amount of ventilation for say a small consultation room, and across a larger waiting room you might be needing to fit a number of different turbines. So so maybe about $350 per consult room, and $1,000 or so for a larger waiting room, something like that.
I mean, I think we did explicitly. I'm just trying to think, when in the costing of the retrofits, that did include specifically turbines, didn't it? I mean, this work suggesting that turbines could be a good solution which helps with thermal comfort, that's new information. But I think the cost effectiveness data did, that was an option that we did cost. So I think that would be relevant to that. I don't know if Fiamma, do you want to comment on that?
I think it included both the turbine and the heaters, didn't it?
That's correct. The turbines were costed as part of the retrofits, and the heaters were part of the enablers for several of the interventions.
Yeah. So extremely cost effective. In fact, cost saving, I think that one, wasn't it?
The retrofits overall were cost saving, although that includes a combination of punching in new windows, putting outdoor waiting areas, as well as the whirly birds. So we couldn't attribute the effect to either of those interventions with any certainty. It was a bundle of retrofits.
But if you got the increased air changes that you estimated, then that would be within that estimate. So yeah, so basically, very, very good idea. We can persuade the policymakers it will save money. Hurrah.
Thanks very much. I noticed there's a few more comments in the chat and people are dropping off. If those of you who are presenting wouldn't mind just staying on and either responding to those questions verbally or just typing in your responses, we can collect those and make sure the people who ask them get the answers.
Sure. I mean, I'm fine to stay a little bit longer. I'm not seeing the Q&A at the moment. I don't know quite why not. So I don't know how I've managed to lose it. Let me just see if I can find it again. Oh, here it is. Okay. Let's see what we've got.
So we have one that says, any thoughts on low-cost community interventions, since you model that 80% of transmission occurs outside facilities?
So yeah, so I mean, we were very specifically concentrating on the clinic context. So yeah, I don't think we can really comment on outside of the clinic. We were thinking that the project was very specifically about within clinics.
And then another one here, just experience from the Zero TB Karachi project. The maintenance of GUV lights is an issue, so really interested from an implementation perspective and accountability of who maintains and checks GUV radiation levels on a regular basis. I do think people in the Free State have some experience on that, but I wonder what you have to say.
Yeah, so absolutely, and we did. I mean, we were quite careful. One of the things I think is perhaps a little bit different about the cost effectiveness was that we went to a lot of trouble to cost in all of these things like maintenance, like training, like all of that sort of stuff. So all of that is taken into account, and the GUV intervention was again very cost effective. You know, even taking into account that all of those things absolutely do need to be done. Yeah, I'm sorry that I've missed some of these. I wasn't seeing some of these Q&As. So yes, it's great to see that people are putting in UV GI. And thank you, Senior Sember, for listening in. It was lovely to have you on the project.
Thank you so much to Alison and her team. If we have somehow missed your question, we will ensure that the speakers respond via mail. And with just 3 minutes over time, I'd like to thank everyone in attendance today. Thank you for your time, and especially to our speakers. Thank you so much for the presentation, as well as take into consideration the different time zones. So thank you very much for that. And everyone else, I'll see you again next month on the 16th of October at 12 noon. For our next webinar session, and enjoy the rest of your day. Thank you.
Thank you so much. Thanks for the opportunity.
Thank you so much.
Thank you. Bye-bye.
Bye.